Welcome back to Voices of Long COVID. I'm your host, Noelle. This season, I'll be bringing you strategies and support for living with our condition and discussing current themes around the topic of long COVID. I hope you'll find the information useful. Today's episode is one that hits especially close to the heart. We're talking about long COVID in children. While early narratives told a story of kids being nearly immune to the long-term impacts of COVID-19, families across the world are telling a very different story. Children who were once vibrant, energetic, and thriving are now facing debilitating symptoms, medical gaslighting, and gaps in care. To help us explore this subject, I'm honored to be joined by two of the world's leading experts in pediatric long COVID. Dr. Danilo Buonsenso is a pediatrician at Gemelli University Hospital and member of the research committee of the Global Health Research Institute of Catholic University of Rome. He has a PhD in public health and molecular sciences and a postgraduate diploma and MSc in pediatric infectious diseases at Oxford University. He is actively involved in several national and international studies and societies in the field of pediatric infectious diseases, and in particular on long COVID, investigating biomarkers and disease pathways. Welcome, Dr. Buonsenso.
Hi.
And also joining me is Dr. Lael Yonker. She is the director of the Pediatric COVID-19 Biorepository at Massachusetts General Hospital, director of the MGH Cystic Fibrosis Center and Therapeutic Development Center, and associate professor of pediatrics at Harvard Medical School. Since the outset of the COVID-19 pandemic, she has led pediatric COVID-19 research and has helped shape our understanding of how SARS-CoV-2 affects newborns, infants, children, and young adults. Dr. Yonker is currently investigating mechanisms driving long COVID in children and is leading a clinical trial. Welcome, Dr. Yonker.
Hello. Thanks for having us.
Thank you both so much for being here. I know your time is precious. Let's start with the science. Dr. Buonsenso, what do we know so far about the medical understanding of long COVID in children? How is it both similar and different to what we see in adults?
So many people tells me we don't know, we still don't know a lot about long COVID. But what I usually reply to this question is that, in my opinion, long COVID in general is one of the most studied diseases in the history ever, really. I think we don't have many other diseases with such a large amount of publications using very last generations tools, both from basic science and epidemiological cohort studies, like in long COVID, literally. We don't know everything, but I would say we know a lot. We know that long COVID is a real biological disease following SARS-CoV-2 infections characterized by a well-established cohort of symptoms. Some of them, in my opinion, are common to adults and adolescents, at least. Some may be more age specific. But the core symptoms like extreme fatigue and post-exertional malaise after minimal physical and or cognitive efforts are common, in my opinion, at least in adults and adolescents. They may be they may manifest differently. Like in adults, it is manifested with difficulties in daily life, which is mostly going to work, so inability to work as they were doing. In children, presentation may be more subtle because children may struggle to attend school, and this from families or teachers most of the time is linked to like psychological or psychiatric diseases. So this maybe like a cognitive bias from the other perspectives, not from the patients, making the recognition more difficult. Other symptoms like gastrointestinal pains and other gastrointestinal issues may be commoner in younger children, but I would say we know a lot in general, to make it short, and the core symptoms, extreme fatigue, which impacts negatively daily life, and post-exertional malaise are the core symptoms both in adults and adolescents at least.
Dr. Yonker, can you talk about how long COVID typically manifests in kids?
Sure, there's actually two really great publications that have come out from the Recover Pediatrics group. One just came out a few days ago, in fact, looking at symptoms that are more common in kids after they've had SARS-CoV-2 infection compared to those who have been uninfected. So there was a paper that came out last summer looking at symptoms in school-age children and adolescents. And like Danilo was saying, fatigue is very common in these age groups. Abdominal pain is very common in the school-age children, headaches, muscle pain, things that you also see in adults, but might be vocalized a little bit differently in younger kids. But importantly, in the younger kids, their sort of impact is refusal to go to school. And so that's, definitely concerning. In younger kids, so this is the paper that just came out last week, in infants and toddlers, they looked at ages 0 through 5, and they found that there were symptoms that were more common after SARS-CoV-2 infection, even in infants and toddlers, like difficulty sleeping, chronic cough, poor appetite. And, again, that wasn't necessarily labeled as long COVID, but these are symptoms that are increasingly more common as a result of the infection. And then in older school age, or not older, but toddlers, again, fatigue, more sleepy than kids who are uninfected, low energy, and a cough. So it's interesting that even without using the term long COVID in kids, because I think it's not readily accepted in pediatrics yet, especially in younger ages, that long COVID is a real entity. But if you look at symptoms that persist, that impact daily life, impact activities or feeding or things like that, there are definitely these symptoms that persist. And so recognizing that is a challenge, and something that, having this podcast is a really great step in the right direction to try to increase awareness.
Mm-hmm. And it's difficult for children, especially the younger ones, to verbalize what they're going through.
Right.
So yeah, it's challenging. What effect does long COVID have on the neurological, cardiovascular, respiratory, and gastrointestinal systems of children?
On the very long term, of course, we don't know yet, but we know so far, at least since 2020, 2021, that there are indeed effects of the infection of the systems you mentioned. I will start for now on the cardiovascular side, and because I think it's one of the most frequent and relevant in the all long COVID cohort, and particularly in adolescents and adults, including young adults, which is the posterior orthostatic tachycardia syndrome, or anyway the spectrum of inappropriate tachycardia syndrome. So this is one of the commonest issue in these patients, characterized by very high rates of heart rate in these patients, following really minimal movements, so like just standing up or walking a few meters. These patients most of the time feel these impressive tachycardias, or this problem can be manifested like with vertigos or fainting, headaches. This is for sure contributing with the fatigue these patients experience, peripheral arms and limbs discoloration, just to mention a few. Not mentioning also that these patients very frequently report chest pains, and some patients have also complained of mild but recurrent pericarditis. So this just to mention the cardiovascular perspective. From the cognitive perspective, we don't have yet all the studies we have in adults, but we are having more and more children that are literally missing 50 to 100% of their school time because of inability to concentrate, to focus. And this, in the long term, is bringing children out of school. And this is, we still need more studies on that perspective, but school absenteeism following COVID and in patients long COVID is being a bigger problem. From the respiratory perspective, I will leave maybe to Lael, which is since before COVID a big expert in the field.
Yeah, so from a respiratory perspective, sort of generally the lung function seems to be okay. I actually think there's probably a little bit more nuance that we could understand about, either reservoirs that might be in the upper airway in some children. But more so, people do have shortness of breath, especially with exercise. But I actually think that that's what's probably driving that is more of a cardiovascular sort of perfusion, blood getting to sort of all of the right places and getting oxygenated to its full extent and being able to get that oxygen circulating through to all of the muscles as they need it. So I think that there's actually more complexity than it just being a breathing problem. I think there's more of a circulation component that is driving this ability to get the oxygen from the lungs into the circulation. Regarding the neurologic symptoms, there was a really nice study out looking at a neuropsychiatric symptoms following MIS-C. And if we think of MIS-C, which is multi-system inflammatory syndrome in children, which is the very first post-acute sequelae of COVID, and it seems to follow along the same spectrum of long COVID. MIS-C occurs, weeks to months after acute infection with SARS-CoV-2, but they come in very sick, high fevers, but all of the same organs are affected, and it seems as though there's the same pathology as long COVID. So we've learned a lot from MIS-C. Anyways, in this study, they looked at neuropsychiatric assessments of children with MIS-C 6 months after they recovered, and they found that these kids with MIS-C had worse memory, worse executive functioning. They had higher depression scores. They just felt pain more, and they had lower qualities of life. And they just came out just recently, a 2-year follow-up, and these symptoms do improve. They're not totally restored, but they're much better. And so I think that there is again, what we're learning from MIS-C is there is definitely some real neuropsychiatric impact that occurs following SARS-CoV-2 infection, and it's multifactorial, but we definitely need to keep an eye on all of these things.
So anecdotally, I've talked to a lot of people, and it seems that there's a lot of people like myself who never had respiratory symptoms, and it was just purely neurological and gastrointestinal. It sounds like maybe in a general way, you're saying that's what you're seeing in kids more often. Is that accurate?
Yeah, I do think that we also see, it's very variable, but definitely more of a GI phenotype in kids. I think it's interesting that these younger children, infants and toddlers, have more cough and respiratory symptoms, which we don't see as much with the older. I think that needs to be understood a little bit more, what's driving that. But you're right. It's I think the pulmonary symptoms are sort of fatigue, maybe articulated slightly differently.
I entirely agree on that. Yes.
Do we yet have a working definition of pediatric long COVID that's accepted internationally?
I would say we have a number of definitions, but we have from looking at an international perspective, we have a formal WHO definition, which has been specifically developed for children and adolescents. So we may agree or disagree, or agree in part or disagree in part with this definition, but indeed we do have a formal international definition, and this is from the World Health Organization. So I would say yes. And again, this definition may seem broad, as we have patients with a confirmed or highly suspected COVID or SARS-CoV-2 infection, and since then they are having long-term persisting symptoms for at least 8 to 12 weeks, according to a number of definitions. But I want to highlight one point of this definition that usually is very commonly overlooked, even in publications. Long COVID is not just a list of symptoms following an event like infection, but it's a list of severe symptoms that impact daily life, meaning that patients are not able to do those things that were able to do before the infection. I think this is critical, because if you ask me or Lael if we have had headache in the last week, or we have suffered from fatigue, I think we both say yes, like the majority of the population. But if you ask us, have you been so tired, so cognitively impaired, so you had such a strong headache that didn't allow you to attend your job for most of the time, this is completely different. And this is long COVID. And when it's about children, what they usually do is going to school, going out with friends, or doing some extrascholastic activities like playing piano or football or whatever. And they were doing these activities like for 10 or 15 years, and suddenly they want to go there, they struggle to go there, but eventually they give up. So I think many people don't like the definitions, but I think it's in medicine there are not clinical diagnoses that are 100% accurate, and this is valid for community-acquired pneumonia or even bronchiolitis, the commonest pediatric disorders. They are not 100% accurate. Maybe this definition as well, but if you pay attention to these clues on the daily impact and exclude other comorbidities that can explain the fatigue, etc., eventually it's really possible to have a proper diagnosis.
And yeah, definitely listen to your children, right? If they're suddenly unable to do the things that they love, that's a really big clue. Yeah. Was there anything you wanted to add to that, Dr. Yonker?
I really appreciate that the WHO put together a specific pediatric long COVID definition. Actually, it's a post-acute sequelae of pediatric COVID. I think the field is sort of moving away from the PASC terminology and really embracing long COVID. And I think that this is something we should, I think that the definition should be revisited. I do think it's important to label it as pediatric long COVID, because it just draws attention to the fact that this can happen in children as well. And so I think having a definition is important. I think it needs to be, revised and reshaped slightly over time, and also sort of brought to people's attention that it's not just an old definition that we're not paying attention to anymore, but this is something that people are still experiencing and we need to refresh it. So that's my two cents.
I agree. We'll be back to our interview after a short break. This podcast is dedicated to all the long COVID sufferers out there. I hope you find a sense of community by hearing these episodes, and maybe find some tips on how to make living with this illness just a little bit easier. One of the biggest challenges has been measuring how common long COVID is in children, especially now that widespread testing has stopped. What does the latest research say about the prevalence of long COVID in kids? Do we know the number of children who are affected worldwide?
So, I'm going to reference again the article by Rachel Gross, was the lead author on both of these, and they were published in JAMA Pediatrics. Again, it's not a definition of long COVID, so it's a different question. I mean, I'm going to answer a slightly different question. How many people have lasting symptoms? And to Danilo's point is, does it sort of reach criteria that these symptoms are impacting their daily life? I don't have that answer, but what I would say is, based on their research of, over 5,000, I think it was over 5,000 children, 6 through teenagers, and roughly 500 infants and toddlers, about 1 in 5 children have these persisting symptoms after they have SARS-CoV-2. So that's about, 20%. That's pretty significant. And again, the numbers are slightly different for younger toddlers and infants, but a lot of kids are experiencing symptoms. Are they, the numbers are going to be lower for those who have a definition or a diagnosis of long COVID, because they're not as good self-advocates. Pediatricians don't have great guidance on how to assign a diagnosis of long COVID. And there are lots of barriers, basically, to being able to trying to understand all of these somewhat vague symptoms coalesce under a unifying diagnosis. So I think the diagnosis I don't have, but we do have data to suggest that kids experience long COVID symptoms at pretty high rates.
Yeah, it's a complex issue. Dr. Buonsenso?
I only want to link myself to a few words that Lael has used, which is to assign a diagnosis of long COVID. Here we have another big problem, which is like a bug in a system, as I call it, because like in the large majority of the world, the national health system do not have a formal diagnostic code for long COVID. I think in the US there is, since not a long time, but in the large majority of the rest of the world there is not. So this makes things even more complex to understand what is long COVID, because most of the time patients need to go by themselves to different specialists, because patients may have cognitive problems, palpitations, and neuropathies, blah, blah, blah. So eventually they are classified as having one or more conditions, even new onset neuropsychiatric disorders in people that have never had any issues before. But in the large majority of the world, they will never have, at least for now, a formal diagnosis of long COVID, which is recorded as long COVID in the national health system. So this makes nowadays, I think, impossible to say the real number, but I would just say there are a lot of people around, enough to justify policymakers, founders, companies, no profits, to try to fund as much as possible this disease, the research in this disease.
And one other comment is, if I were to coalesce the various data, it would be probably, somewhere between 6 to 10%. But when you're walking around, like, that feels even high to me as a parent and as sort of a citizen in society, because if you're walking around, you can't tell that somebody has long COVID, right? So, and it is a natural tendency. See this I saw this through my training as a pediatrician. People sort of expect kids to be fine, and sort of that, so, you can tell when somebody has a medical condition that has more physical features or impacts their ability to walk or things like that you can't tell by looking at kids as much. So, but I think that's what the various reports would say, somewhere, under 10%, but somewhere around there, which is actually a lot.
It's too many. Yeah.
Yeah.
Are we seeing any patterns in terms of age, gender, or prior health in the kids who have been affected by long COVID?
In my experience, I mostly see adolescents and pre-adolescents, so the age group 7 to 18. In the meantime, I've also expanded to accept patients up initially to 20, then 25, then 30, because no one is taking care of young people in general. But focusing on children, the commonest age group for me is 10 to 18. Maybe a slight majority of um, women, but of girls and women, but not as much as it is reported maybe in adults. So just a little majority of women, but not as much. And in terms of pre-existing comorbidities, I know I may have a different experience compared to other cohorts, particularly from the UK. But in my experience, most of the children were previously healthy children, which had, if I have to think at one comorbidity, like allergic disorders. This is something commoner in my experience. It may also be to the fact that as I try to be as much specific as possible with the diagnosis, I usually refer to long COVID to previously healthy children with no other confounding factors that suddenly have their quality of life and routines completely changed since the infection. So this may be a bias, but in my experience, mostly previously healthy with some minor allergies, having then all the symptoms we discussed earlier.
Yeah, I was gonna say I've seen some patients too who seem to have some underlying predisposition in the sense that they've had Ehlers-Danlos or something, and then they get COVID, and then their symptoms are so much worse. So there might be there probably are some genetic predisposing factors, which we don't fully understand at this point. But I agree, the vast majority had, their lives had really shifted. But there are some who had some symptoms, but then COVID really pushed them.
Yeah, that's true for me as well. I'm in Canada, where we are definitely behind in terms of treating long COVID in adults, and even further behind in terms of treating children. Are you seeing discrepancies in care across different parts of the world?
No, so this is something I always tell patients when they contact me from other countries, and they always tell me, in this country, we are behind because there is no treatment for long COVID. And what I reply is, well, it's the same everywhere in the world because there is no treatment for long COVID. So this is uh, so basically there is no one country behind or ahead another because formally we don't have a treatment for long COVID. It's not pneumonia. We have an antibiotic or whatever. So we are everyone at the same level. The only difference in some cases is that, in my opinion, as I said before, we, of course, so some countries may be ahead in terms of having implemented some trials or research spaces for long COVID, either for biomarkers or whatever. And but everyone is behind. The problem here is that long COVID and myalgic encephalomyelitis, in my personal feeling, will not have a formal treatment within the next 5 to 10 years, and I feel I'm optimistic when I say that, for several reasons. Because trials may even fail finding the proper medication because it is very difficult to agree on an outcome that can be measured and quantified for a trial. So I'm very skeptic in terms of one trial will find a response. So this means either we don't find a single medication and we may need more medications to treat this condition, and this is making almost impossible to do big trials, or we have the right medication but we don't measure the outcomes properly, or we don't select patients properly. So said this, sorry for like this was the incipit, the premise. So we are everyone behind. Some of us are trying off-label medications for the most severe cases, and this is not because the system is behind or above someone else. It's, in my personal case, it was very difficult from an ethical perspective, saying like a 15-year-old patient previously healthy who is now 20 hours a day bedbound, who is thinking multiple times to suicide because he's not able to do anything, just to say wait or go to the psychologist. So in this case, with proper discussions with family, we said, okay, we know that long COVID can have this immunological background, these findings from endothelial inflammations, these findings in terms of microbiota, blah, blah, blah. And in the most severe cases, we are trying, some of us, off-label conditions if we are in settings or countries where we don't have yet the resources to implement a trial in the field. So basically, patients need to know that we are all behind. There is no country formally ahead. It's eventually then some doctors use off-label medication. And I want to add, sorry if I'm going along with this,
That's okay.
just one sentence. Using off-label medication is nothing new in medicine, and particularly in pediatrics, because the large majority of medications we use daily in our practice are kind of translated or extrapolated from the adult practice. I can think at antibiotics, for example. Most antibiotics we use in newborns or in prematures have never been tested in formal trials, but we kind of adapt from other trials. So in general, I agree it's difficult with the trials, but don't tell me off-label is not part of our daily medicine, because it is part of our daily medicine. It's just if we agree that long COVID is a severe disease as like any other severe infections or not.
Mm-hmm. Dr. Yonker?
I agree that we're all behind. I don't think that there's any difference in, regions or countries. There are, I would say there are, there are long COVID clinics in the US, and that helps. And you get, generally you get referred to specialists to try to help, and there are varying degrees of guidance you can get, but what we really need is formal guidelines on how to treat the symptoms of long COVID in different age groups. And I think that Danilo's absolutely right. Right now, we can't wait 5 to 10 years for true treatments, and even waiting, a long time for some of the clinical trials. It's right to wait for these clinical trials, but there are many treatments out there, and we can't run through each individual treatment when we know that the concept that we're treating is effective and has been shown in other sort of scenarios. So I think we need really clear clinical guidance across all ages of what people can do, and these should be publicly available. So, families who've proven to be really good advocates for themselves across many diseases, but particularly in long COVID, because there's been a struggle with getting people to understand. I think that's really an important next step.
Are there any signs or symptoms that teachers or caregivers should be watching for, especially in children who may not articulate their fatigue or brain fog clearly?
I'd say just a drop off in engagement in school, maybe lack of attention or just not participating, not attending school. Like these sort of things should certainly raise some flags, but generally just not feeling good, not engaging in the normal activities. And parents, school teachers and caregivers should definitely share this with parents. I mean, and see if this is also happening at home or what else is going on there. There could be many reasons for this. And so long COVID is one of the reasons, but it is something that parents should be aware of and then talk to their doctor about.
Yeah, I agree. I agree that teachers can play a critical role in recognition, but also eventually in supporting the process of care and support for these children. So it's like standard of practice for me now to refer and collaborate with schools and finding solutions. So now these patients that want to go to school but struggle to do that, so how to support in this process, because there is a very delicate balance on patients that do not to be pushed too much because this can trigger post-exceptional malaise, but also doing too little for children and adolescents is negative itself. So it's important to find a strategy, a personalized strategy to support patients, and schools and teachers play a critical role along with parents.
Talking a bit more about families, what do you hear most often from the parents of your patients in terms of the challenges they face when seeking care for their child?
Yeah, for me, this is a very easy question and very easy answer, because I've probably heard 500 of times the very same sentence. And I have to say, I've had in-person or online consultations from patients really from all Western countries. And the very common challenge is no one is trusting my son or my daughter is having a problem. Everyone is only sending us to the psychologist because son, my daughter has her issues in her head, like it's pretended or it's just something psychologically to be managed. So eventually, most of these patients go do multiple tests, multiple first-line tests, which are normal. Eventually, even the psychologist says, really, I I don't have anything specific to do for you, and they Google it, eventually discover somehow, like most of the time from podcasts or from some occasional news, that this may be something related to the COVID infection, and arrive to those of us dealing with the issue.
Dr. Yonker?
Yeah, I agree that it's often that they weren't believed for a long time, or sort of like they were told, this could be long COVID, but we don't have anything that we can do about it. So frustration, even I think going to specialized clinics can be frustrating. It's very variable, but sometimes, you're like, well, they do think, I have this or this, but there's really nothing we can do about it. Or we tried one thing, but there's nothing that it didn't help. And so it's definitely, I think, important to trust your patients. I mean, and to trust your doctor and have a relationship where, you go back if something's not working, and you are paid, we don't want to wait 5 to 10 years, but we do have to be patient. And we don't know what the best treatments are necessarily, but there are a lot of options, and we don't want to just have polypharmacy where we add on or do everything all at once. Drugs can interact with each other, and they can have negative side effects. So we want to be really careful and thoughtful. But I do think that persevering and working through things can be helpful from both the provider and the patient's side. But I think that the message is that they're not being heard, and if they have tried anything, it hasn't worked, or we sort of felt given up on, and so it's hard to hear that.
What would you say to the pediatricians out there who are seeing kids with these symptoms and are unsure of how to proceed?
Well, I would say, part of our job is to network with pediatricians from other specialties. We, as a pediatric, the pediatric area is too broad to know everything, and so we need to know which doctor in the area can support from some specific presentations. So we as a pediatricians need to be aware of the main diseases, the main categories, and try to refer them to the appropriate centers. So my suggestion will be just try to have the minimal level of knowledge about post-viral chronic fatigue syndromes, including long COVID, because more and more children and adolescents are experiencing this disease. You don't need to be an expert. You don't need to formalize the diagnosis, but you need to be aware of the existence, and at least you should be able to suspect the clinical condition, and you should have. I think this disease nowadays is so common that you should have in your network a pediatrician or a colleague to refer these patients.
Dr. Yonker?
Yeah, I agree. And again, I do think that guidelines for things to be able to try or assess and prioritize across different ages would be really helpful. And there are some guidelines that were developed to recommend how to work up and rule out possible alternative diagnoses. But I think, again, these should be refreshed with what we have learned over time. And I agree. I think having a network and knowing when to reach out to colleagues, we do this all the time. And so same for patients who have long COVID.
Both of you are doing such vital work in this area. What comes next? What do you see as the most urgent research priorities when it comes to long COVID in children?
I think identifying a biomarker is just essential. And actually, I think it's not only important to include children in research, but I really think we will learn a lot from children, as we have with Miss C. That's gave us the earliest insight as to what is driving these post-acute sequelae of COVID, but also children don't have those other hyperinflammatory or other comorbidities that we all develop as we age. And so their immune responses are more pure and simple. And so I shouldn't say simple, but less likely to have things like diabetes or high blood pressure or other sort of conditions that can impact what's actually driving. So they'll be really helpful. Children will be really helpful to try to identify biomarkers. And I think that's really, we don't have biomarkers. We can't really see if a treatment is who has long COVID truly, as opposed to other post-infectious symptoms from another infection or other, conditions. And then also it would be good to have nice biomarkers, early biomarkers to see response to treatments.
Yes, biomarkers and pharmacological trials. And I agree with Lael. So basically, usually we have the trials the studies in adults, we have to replicate or translate them in pediatrics. But eventually, particularly for long COVID and post-viral chronic fatigue syndrome, we should do the opposite, because even from a scientific perspective, pediatric patients are the perfect models, to allow me to say model, in brackets, to study this condition. Because eventually, since I started also seeing adults for a number of reasons, it's much more complex in adults when they have all the comorbidities and whatever, even in terms of having effective pharmacological treatments and see what happens on the outcomes. In children, most of the time, they're perfectly healthy, and so they really should be the focus also of policymakers and pharmacists. This need to be made clear. Right? The condition is common in pediatrics, and pediatrics are the perfect model to understand this disease, which is affecting millions of people all over ages around the world. So basically, we need to make it loud.
Finally, what message would you offer to parents and children who are living with long COVID right now and feeling unheard or unseen?
Well, I would say for the last 4 years, I know very well that we have been unseen and unheard, but now things are really changing, and in publications, papers, lots more people, doctors, and the public opinion is talking about long COVID and other post-viral chronic fatigue syndrome. So don't lose your hope, because now we are really strongly being seen and heard. And this means that more centers will be implemented to provide the support you need. And eventually, I'm sure we will find also the way to treat this condition.
And I would add, make yourself heard, join advocacy groups, talk to your legislators, talk to, the funders, and try to get pediatric long COVID recognized and prioritized, and share your story. Because again, if people don't, you can't tell by looking at somebody that they have long COVID. So share your story with your community, your local foundation, your legislature. Again, trying to organize efforts, and this podcast is a wonderful example. You're spreading the word, and the more we talk about it and let people know what people are experiencing and how their lives have been altered, the more attention it'll get. And then the more attention it'll get, the more people will start doing the things that need to happen to finally get some cures.
Thank you so much, Dr. Yonker and Dr. Buonsenso, for all of your ongoing hard work for children and their families, and for sharing your time with me today. Conversation around this topic is so desperately needed. Thank you.
Thank you.
My pleasure. Bye-bye. Thanks a lot.
This episode is dedicated to Ethan, Leah, and all the millions of children who are waiting for help and answers. To everyone listening, long COVID in kids isn't rare, imaginary, or insignificant. It's real, it's life-altering, and it deserves urgent attention. Children are not immune to this virus or its long-term consequences, and they deserve protection. If this episode resonated with you, please share it with the people in your community, educators, and healthcare providers. Awareness is the first step toward change. And if you're a parent or young person facing this illness, know that you are not alone. There is a growing community working to make sure your voice is heard. Until next time, stay safe and stay informed.